Diabetes is a systemic disease of great importance among the medical fraternity. 537 million people diabetics are present in the world. World Health Organization has declared diabetes as an epidemic. In 2018, epidemiologists in United States of America stated that 1 in 3 people are pre-diabetics, and 84% of the people who are diagnosed to be diabetes do not know that they are diabetics at the time of diagnosis. In India, 2019 statistics showed that 77 million people are diabetics, and this figure is likely to go up by 84% in 2045. If you see the occurrence of diabetic retinopathy among diabetics is 35%, and if you consider sight-threatening diabetic retinopathy, it is 11.7%. If we consider the risk factors for development and progression of diabetic retinopathy, they can be broadly classified as modifiable and non-modifiable risk factors. If you see the non-modifiable risk factors, duration of diabetes, puberty and pregnancy are important. If you consider modifiable risk factors, tight control of HbA1c levels, blood pressure, lipid profile and waist to hip ratio are important. DCCT trial has showed that tight control of HbA1c levels reduces the diabetic retinopathy progression by 75%, and a tight control of blood pressure reduces the progression and development of diabetic retinopathy by 34%. If the field trial showed that the lipid modifying agents like fenofibrate reduces the need for laser in diabetic macular edema by 30%. When the patient of diabetes presents in the clinic at the stage of mild to moderate non-proliferative diabetic retinopathy, these patients shall be screened for Hb%, lipid profile, microalbuminuria, diabetic foot, in addition to good control of blood sugar. The ocular investigation shall include fluorescein angiography, RPE autofluorescence, OCT angiography and ultrasound B scan as indicated by the clinical condition. When the patient in the clinic detected to have very severe non-proliferative diabetic retinopathy, early proliferative diabetic retinopathy, high-risk proliferative diabetic retinopathy, one should consider panretinal photocoagulation. If advanced stages of diabetic retinopathy and associated complications are there in the given patient, then one should consider vitreoretinal surgery by experienced VR surgeon. Screening for diabetic retinopathy among diabetics is very crucial. If a person who is detected to be diabetes is below 30 years, then the first screening for diabetic retinopathy shall be done within 5 years of detection of diabetes. However, if the same person is above 30 years, then screening for diabetic retinopathy shall be done immediately at the time of detection of diabetes. During pregnancy, one should screen for diabetic retinopathy during first trimester of pregnancy. Follow-up of patient with diabetic retinopathy in the clinic is very essential. If the patient is having no diabetic retinopathy or minimal diabetic retinopathy, this patient requires an annual checkup. However, A mild to moderate non-proliferative diabetic retinopathy patient requires to be called once in 6 months to 12 months. If the diabetic retinopathy is moderate to severe non-proliferative diabetic retinopathy, then the follow-up should be once in 3 to 4 months. Teleophthalmology and artificial intelligence based screening of diabetic retinopathy is very important, and this reduces the requirement of resources in diabetic retinopathy screening. Though it is not so prevalent at this point of time, in future it's likely to be used much more often. Overall management of diabetic retinopathy is a concept. This concept needs to be understood very well by each and every ophthalmologist in the country, so that the blindness due to diabetic retinopathy can be prevented and reduced by application of knowledge of management of diabetic retinopathy.